Again, my poor husband, every time he takes a drink of a whiskey, I say, put that down, you're gonna get throat cancer. So he tells me I am the, he says I'm the referee for the NFL, the No Fun League, is what he says to my kids. He says, your mom's being the referee for an NFL, the No Fun League, because I always tell them they can't do this, but he says, yes, you can do it. So I'm the referee for the NFL. He thinks he's so funny. So most of these people, smoking and drinkers, for the majority of laryngeal cancers. So most of the times we would see these on their true vocal cords or their glottic. And then you have supraglottic, which is in front of the vocal cords. Subglottic, which is below the vocal cords, weren't as common. I did see them, but they're definitely not as common as true vocal cords or supraglottic. So supraglottic is around the epiglottis or right there in that vallecula. So when patients show up to the clinic, when they have a glottic or subglottic tumor, most of them are complaining of hoarseness. They're like, I've had this chronic hoarseness for about a month now, and it just won't go away. So those patients, especially if they're smokers, I worry about that. So I actually had a patient, again, so I was like, why do all these people in internal medicine want to follow me to the head and neck clinic? But I had a patient, is actually before I was working part-time in both of them. He came into my office, and it was around the fall. He was complaining of hoarseness. He had actually seen Dr. T back in early fall, like August or something like that, and was diagnosed with like an upper respiratory infection, because around that time, allergies, drainage, things like that. But his hoarseness never went away. So he came back to see me and told me he still has his hoarseness, but he didn't have any other symptoms except for just the hoarseness that still lingered. So he has a history of being a smoker. He still smoked. And so I referred him over to the head and neck clinic, and they scoped him, and he had a vocal cord cancer. So someone who smokes, complains of hoarseness that's been longer than 2 weeks, they need to be looked at by somebody. Usually subglottic patients will have airway obstruction, so they have difficulty breathing or shortness of breath. Yeah?
Kind of just for all of these in general, I'm just kind of thinking urgent care minded. So I don't know what I'm trying to say. So if you have a patient that comes in and you don't have the utensils clearly to see any of this, is it kind of the common rule is if it persists more than 2 weeks, you need to go to ENT?
Yeah, we probably should refer them, because it could be allergies, which it could be. But again, you're looking at your patient. Now, if it's a young, like if you came in and you're still hoarse after 2 weeks, and like Leah had said earlier, and you're someone who cheers and you go to games and scream, or have allergies, then I might be less concerned that it would be cancer. But if you still have the hoarseness, past 2 to 3 weeks, I would send you to go get scoped anyway.
Okay.
Because then it could be that you have chronic allergies, and then they would treat the allergies, and then your hoarseness would go away.
Okay.
But if it's someone who came in and he's a smoker, you saw him, but acutely, anybody who is a smoker, just because you have hoarseness and you have an acute laryngitis doesn't mean you have cancer. But if it doesn't go away and they're a smoker, you definitely need to have them be seen.
Okay.
And then most of our patients who came in with a supraglottic tumor, since it's not sitting on their vocal cord, they're not really having hoarseness. These people have a sensation of something stuck in their throat, or they have difficulty swallowing or pain when they swallow, or they get choked up all the time, the dysphagia. And the dinophagia is just painful swallowing. And then again, these people can have referred ear pain as well. So see, a lot of common symptoms that everyone has, but just because you have so many common symptoms doesn't mean you're going to have cancer. But again, you've got to look at your patient, think about their history, how long they've had things, and determine when you need to refer them. So again, cancer patients sometimes will just show up with a neck mass. We'd scope them, take a look at their vocal cords, and then they've got this lesion on their vocal cords. A lot of times the patient might have unintentional weight loss. They'll say, I've been hoarse and all of a sudden I'm starting to lose weight. Depending on where the tumor is, they may not be eating because it hurts to eat or having difficulty swallowing. That's why they're losing weight. So a lot of times you'll see them, you can have a vocal cord lesion. Sometimes you can have paresis or paralysis of that vocal cord as well. these are some big tumors you can see. So you can see how that one on the right, or the lower left picture, how that vocal cord may not move well. Up top is a supraglottic tumor. And then down below on the far right, you can see a small glottic tumor there. So this one, you're looking, so when I scope them, sometimes you scope them, depends on which way you look at them. But this is your posterior side, because back here is your esophageal inlet. And so here's your epiglottis, so when people swallow, like Leah was talking about, this will flap over, cover your vocal cords, and the food will shoot down into the esophageal inlet.
Hi, and welcome to Smarty Pants.
And so this is the piriform sinuses, so a lot of cancers can hide there. So when I see people and scope them, I make them say E, so then it will close this, their retinoids will close together, and I'll be able to see the piriform sinus better. And then down here is the vallecula, where tumors like to hide as well. And so how do you diagnose with someone with that? You scope them or send them somewhere that they can be scoped. They'll usually have a inter or operative endoscopy and biopsy, and then they'll do imaging for staging purposes. So a lot of these, if these glottic tumors are caught early, if they have a small lesion on their vocal cord, they can usually get that taken off. So if they have like a leukoplakia on their vocal cords or a small tumor on the cords, they can usually cauterize those off. Or they can be treated with radiation. A lot of times it's usually radiation. Leukoplakia can be usually taken off. But now if they have big tumors wrapped around everything and it's horrible, then they will have to have a total laryngectomy and they'll reconstruct their pharynx. So that's what a stoma looks like. I remember the first time, like I said, the first time I ever saw a total laryngectomy patient. They came in, they were been in the hospital for 2 weeks or whatever, and they were coming to me to take out their sutures around their stoma. So needless to say, I was scared as all get out that I was going to drop a stitch into their windpipe. Because when they stitch it, it's like deep down underneath there. So I really had to get down in it, hold on to that suture really tightly and clip it and pull it out. And these sutures around that stoma are not just like the small 5/0, 6/0, they're like really thick sutures to kind of keep that area together. And then sometimes they have a red rubber catheter in there because they're not able to eat and drink yet, because they may have a fistula or something like that. And so there's all kinds of complications. And luckily, the speech path that I worked with, her name was Tracy, she's a guru of laryngectomy, and so she would always, I could always call her if I had any questions or send the patient downstairs to see her for any type of stoma care. There's the same treatments, like I said, they can have. And then if they have distant metastases or a large tumor, they may would have to have adjuvant chemotherapy. So it all depends on the tumor size, huh?
We would have our kids at the children's center when they got their trachs out. They would have a big old trach stoma and they would let it